Hello, good evening, everybody, and welcome to this webinar. So the topic of the webinar today is making the best use of imaging. So my name is Jack Forth. I'm the Business Development Manager at PhysiQuip. For those of you who don't know, a bit of background about PhysiQuip. We're a medical technology and device distributor. We've got a core focus on rehabilitation technologies, including diagnostic ultrasound, focus shockwave, and lymphotouch. So this evening, I'm sure you can all agree, we're very, very privileged to be joined by our guests, Dr. Shub Basu and Dr. Jain. They're going to be presenting for us today. Following the presentations this evening, we're going to be having a Q&A session with some fantastic pre-submitted questions, and hopefully we're going to have some time to cover some of the live questions as well. So if you throughout the presentation, if you do have anything that you want to ask, write it down, and then you can put it through the Q&A box. So on that note, I'll pass us over to our first presenter, Dr. Shub. Over to you, Shub.
Thanks, Jack. Thank you very much to PhysiQuip, to Andy, Jack, Katie for the kind invitation to talk tonight. It's a privilege and an honor, and I welcome all the delegates that are watching from home. So my name's Shub Basu, and I'm a musculoskeletal radiologist based just there at Wrightington Hospital in Lancashire, which is a big tertiary orthopedic unit just outside of Wigan. And my remit tonight is going to be talking to you about how we can make the best use of imaging and give you a bit of an overview really of the kind of imaging modalities that we have to hand in the context of MSK radiology. I'm focusing the talk a bit more on and around the shoulder tonight, and I appreciate that there might be some of you that probably don't work with the shoulder or maybe work with other parts of the upper limb or lower limb. So forgive me if some of this may not be relevant, but on the whole, the context should pretty much cover everything. So in terms of shoulder interventions, what do we have in our armory? Well, I've divided the talk into kind of diagnostic and therapeutic shoulder interventions, and focusing on the diagnostic stuff first. What dictates the kind of imaging modality you choose? Well, that often is dictated by the kind of accurate clinical history taking and clerking at the time, and based on those signs and symptoms that you look for and examine for will determine your differential diagnosis and the potential nature of the pathology that might be causing your patient's symptoms. So the common investigations that we tend to use, particularly in musculoskeletal imaging, are radiographs or x-rays, ultrasound, CT, MRI, and arthrograms. And I'm going to touch briefly on each of those imaging modalities this evening. So an x-ray is pretty much a simple, quick and easy imaging test to obtain. It's pretty good looking in the context of trauma for fractures and dislocations around bones and joints, but also it's used a lot in the kind of follow-up of chronic symptoms. So in the context of shoulder, we can talk about pain and weakness or instability, and it gives us a good overview of what the joint is doing. It can also look for calcification and arthritis. Ultrasound. So the pros of ultrasound, well, it's generally easy and quick to perform and readily accessible in most institutions. The good thing about ultrasound is it's a dynamic study. So we have the patient live in front of us. And when you're imaging and scanning the patient, you can talk to the patient, you can manipulate and maneuver the patient's body part, in this case, the shoulder, into various positions to be able to see what you want to see. And ultrasound is very good, certainly in the context of assessment of the rotator cuff for any underlying rotator cuff pathology, but also other structures around the shoulder, like the biceps tendon, the AC joint, and looking for various bursal collections. It is operator dependent, so it is important to appreciate that in the right hands, ultrasound can actually provide valuable information. Some of the drawbacks to ultrasound are, I'll put again here, operator dependent. So again, if it's in the wrong pair of hands or somebody who's not experienced with ultrasound, the information you glean from that will not well be relevant or maybe sketchy. Again, a drawback of being a dynamic live study is that, when we get asked to review ultrasound images, they're often static images performed and acquired at a particular point in time over a particular structure or area of interest. So comparing that with cross-sectional imaging means that, we're just looking at a snapshot, and sometimes that doesn't give us the full picture. When it comes to looking at muscle atrophy, particularly in the context of rotator cuff tears, Ultrasound can have limitations in its accuracy, certainly, and that's where an MRI would be more useful. Ultrasound does have drawbacks looking at the intra-articular structures, so things like the chondral surfaces, intra-articular structures like the glenoid labrum. These are much more difficult to appreciate on ultrasound. And finally, if your patient's struggling to move the arm or shoulder, then you may well have a limited examination because you need to move the arm in various positions to be able to access the different structures that you want to see. Oops. Moving on to CT. So CT is great for identifying osseous morphology. And again, you take it to the next level when it comes to assessment of fractures and dislocations in the acute phase, or looking at the check progress of healing of any fractures or union in the chronic phase. Arthritis can also be assessed on CT, certainly in the context of preoperative planning, if you're looking for surgery and shoulder replacement surgery, and also for implant imaging, those patients that may have underlying joint replacements. CT is reasonably good at being able to scan around those with kind of newer metal artifact reduction sequences. CT's got good spatial resolution, and we can discriminate really well between cortical and cancellous bone. The drawbacks of CT include ionizing radiation, which is very important, particularly if you're dealing with a young cohort, young age group cohort of patients. But it also has a poor soft tissue contrast resolution when you compare it with ultrasound or MRI when you're looking at the soft tissues and muscles, for example, the rotator cuff. So that may be a consideration based on your clinical findings. Moving on to MRI, MRI has a superior soft tissue contrast capability compared to CT, and you can discriminate between fluid, fat, bone, calcium mineralization. So MR is really useful in that regard, and certainly for shoulder imaging, MR is used quite a lot for assessment of rotator cuff disease. It's also superior at looking at the intra-articular structures compared to ultrasound. Some of the drawbacks for MRI include it's not readily accessible always, although having said that, nowadays, there's an MR probably around the corner of every street. It's fairly accessible. And in terms of contraindications, these used to be absolute contraindications where we wouldn't be able to MR patients with pacemakers or metalwork. But nowadays, with the newer machines and in certain institutions, we can image patients with pacemakers. And certainly with metalwork, we can run metal artifact reduction sequences. MRI is time consuming. So compared to an X-ray or a CT, especially with the CT where you can whisk somebody into the scanner and out again and have images taken in a matter of seconds, MRI takes a bit longer. So it can be time consuming. And also don't forget claustrophobia. It's a real life problem with patients. A lot of patients struggle to kind of maintain themselves within the scanner and lie still. And we know that MR is very prone to artifact, even with the slightest of movement. So if your patients struggle to lie down for about 20 minutes, depending on what they're having scanned, just be careful about that and consider alternative imaging modalities that might be better. Arthrograms are essentially injection of contrast into joints, which we do under image guidance. And it doesn't matter whether you do that under fluoroscopy or under ultrasound, you're just using imaging to guide the needle into the joint in question and inject contrast. And we do that to be able to assess the intra-articular structures. So in the context of the shoulder here, we're looking for labral tears. It can outline the chondral surfaces. And we find arthrograms can be quite useful in the context of things like instability. Here's a fluorograph image of what an arthrogram can look like. So we've got a needle entering the glenohumeral joint here through the rotator interval, and the black stuff is the contrast that we've injected around the joint. Commonest indicators for arthrogram procedures with the shoulder tend to be looking for instability and signs of capsulolabral ligamentous disruption. Here's a few images of what a shoulder arthrogram looks like. So on an image on the left, we've got a normal glenohumeral joint that's filling with contrast. The image in the middle is an example, and it's quite subtle actually. I don't know if it's projecting as well on your screens, but there is a suspicion for a Hagel lesion here. The reason being, I can see contrast leaking out from the joint inferiorly. So before this patient goes on to the MR scanner, I'm already in the back of my mind thinking there might be an underlying humeral avulsion of the glenohumeral ligament, and that was confirmed on the subsequent MRI scan, which is the image on the right there. Artifact is always a problem, particularly with metal artifact, and this was a rugby player that had previous anterior stabilization surgery unbeknown to the performing radiologist and radiographer, and they had contrast put in, and they went to the MR scanner, and these are the images that we got. This was on a 3T scanner. So to bail us out, we switched to CT, and you could see on the CT scan, this patient was now presenting with posterior instability symptoms, and there's some subtle glenoid rim fracture of the posterior margin here that can be outlined on the CT scan. There was no way we'd be able to have spotted this with the MR. So CT can often be, CT arthrogram that is, can often be a bailout, particularly when you've got metalwork inside you. So in terms of a summary of the diagnostic shoulder investigations, those were the imaging modalities that I covered there. And just briefly moving on to therapeutic interventions, I'm really focusing just on the common things that we tend to inject. There are, of course, others out there on the market, but the commonest things that we tend to use are corticosteroids that we kind of mix or not mix with local anesthetic. And I'll touch briefly on hydrodilation procedures for frozen shoulder. So guided injections under ultrasound are fairly quick. They're relatively inexpensive and minimally invasive when you compare to alternatives. The reason for using image guidance is really to make sure you improve your accuracy and visualize your actual target area, whether it's a joint or soft tissue lesion, and you can avoid the neurovascular structures. I'm not going to touch too much about the in-plane and out-of-plane techniques. That's probably for another day, but that's the whole point of doing ultrasound guided injections, where planning is important and crucial. It doesn't matter which technique you use as long as you're comfortable with it, and sometimes you're forced into one technique or the other depending on what you're injecting. So for me, out-of-plane techniques I tend to reserve for small joint injections, whether it's in the base of thumb or sometimes in the AC joint, to get into the joint, whereas most injections are probably performed with the in-plane technique. CT guided injections and biopsies can also be done. So CT is utilized as a way of image guidance. And here you can see a needle entering for an epidural injection here. Again, CT guided intervention is a lot more time consuming, does involve more ionizing radiation for sure. And it's not as quick as performing something under ultrasound. However, with the advent of CT, being able to access deeper structures and avoiding key neurovascular structures is important. And that's why you would choose CT over ultrasound in certain instances. Just to kind of wrap on shoulder practice, really, you could divide it into 4 key areas: rotator cuff pathology, glenohumeral joint instability, osteoarthritis, where patients will go on to have shoulder replacement, and then frozen shoulder. So rotator cuff disease, it's very simple in terms of managing it. If you have to perform an injection under ultrasound guidance, and here you can see the kind of area where you place the probe to guide a needle in the in-plane technique into the subacromial bursa. Barbotage for calcific tendinitis follows the same route, where we stick a needle into the calcium and fenestrate it, break it down into multiple fragments, and try and aspirate it with the help of saline, and then inject a bit of cortisone into the overlying subacromial bursa. AC joint injections, as I mentioned, can also be performed under ultrasound guidance, and you can see the image on the left here demonstrating superior capsular thickening with an underlying mildly degenerate AC joint, and you inject these for therapeutic control. Elongated biceps tendinitis, we can inject some low-dose steroid around there if clinically you feel there's an underlying bicipital tendinitis. And rotator cuff arthropathy, a combination of glenohumeral joint arthritis and rotator cuff disease, can be managed, particularly if patients are not fit for surgery, perhaps. They can be managed relatively conservatively with suprascapular nerve blocks, whether we inject them or certain pain colleagues and anesthetists may consider ablation therapy. Just going to skip that slide, and just for time, frozen shoulder or adhesive capsulitis is common and probably one of the biggest conditions I've managed over the kind of last 18 months or so, the pandemic, where we've had a huge increase in presentation. You can perform hydrodilatations under ultrasound or fluoroscopic guidance. Hydrodilation just plays one part. The biggest part, of course, is physiotherapy that underpins the whole thing. So that's very important. And where do patients get benefit from hydrodilatations? Well, we feel it's due to the capsular distension we create by injecting a volume of fluid into the joint and trying to break down the scar tissue around the shoulder capsule. And we inject a mixture of saline and intra-articular steroid, and it's this corticosteroid that will help reduce the inflammation, which will then allow hopefully the patient to be relatively pain-free to start moving their arm and getting on with their physiotherapy. Some patients derive benefit almost immediately, but most will take several weeks to optimize themselves. Here's an X-ray that I'd like to see in a frozen shoulder. This is a normal X-ray of the shoulder where I can rule out any alternative causes for pain here. Here's an example of calcification overlying the rotator cuff, outlining the supraspinatus. So here's a patient that presented with calcific tendinopathy. Here's a patient that's got a full thickness rotator cuff tear, and I can tell that because you've got abnormal superior migration of the humeral head, and you've lost the normal acromiohumeral interval. Here's another example of rotator cuff, this time rotator cuff arthropathy with acromiohumeral interval narrowing, superior migration of the humeral head, and glenohumeral joint arthropathy. And here's another example, not seen frequently, thankfully, but it does come through clinical practice. We've got a lung tumor, we've got a pancreas tumor in that left lung apex, which is that increased density that has mimicked as shoulder pain and frozen shoulder. So these are the kind of key conditions or differentials one should have in the mind if you're looking around shoulder pain and frozen shoulder, and it's something that we'd like to exclude before we stick any needles in. In terms of MRI, frozen shoulder is a clinical diagnosis, but you can make the diagnosis on MRI, and you see features of capsular thickening and synovitis around the rotator interval. A sensitive marker tends to be coracohumeral ligament thickening. So if you see coracohumeral ligament thickening on the MRI, then there's a high likelihood that there's an underlying degree of adhesive capsulitis. And we can see some of these features on the MR scan here. So the images on the left are coronal fluid sensitive sequences demonstrating the glenohumeral joint. And I'm afraid my cursor is not working, but there is thickening of the joint capsule, particularly across the inferior axillary pouch, with evidence of pericapsular edema. That's inflammation around the capsule. And then on the images on the right, which are sagittal sequences, the rotator interval sits surrounding the biceps tendon between the superior border of the subscapularis and the inferior margin of the supraspinatus. And that area usually contains fat. In adhesive capsulitis, that fat gets replaced with soft tissue thickening and scarring. In terms of what we do, we perform a cocktail or inject a cocktail of drugs, really, but I'm not going to go into that today. But here's just an example image of what an adhesive capsulitis and hydrodilatation looks like under fluoroscopy. As we go down the right of the screen progressively, you can see progressive distension of the glenohumeral joint. This is with contrast under X-ray guidance. Of course, most of the time we now do this under ultrasound, but it really does depend on your institution. You can do it in the context of post-trauma. Here's a patient that had a humeral fracture that was plated subsequently and then developed frozen shoulder over the course of their convalescence. And here we've now considered injecting and performing a hydrodilatation where the joint capsule is actually really tight. There's very little distension at the inferior axillary pouch. So this patient did really well after the procedure. And that's all I wanted to say from a diagnostic and therapeutic point of view. This is my website, and I've got quite a few patient videos on here. I know from practice, a lot of patients don't get, not fully aware necessarily of all the procedures that they're having done. So I try and create videos that I can then show the patient to get a better feel for really what their procedure is, and then consent them appropriately. And that's me. Thank you so much. I'm going to switch over now to Neil.
Awesome. Thanks, Shub. A virtual round of applause. Brilliant. I'm going to share my screen and take over. Yeah, so that was all very technical and very intelligent. And me being an orthopedic surgeon, it's probably going to be less technical and certainly less intelligent probably as we go through. My name's Neil Jain. I'm an orthopedic surgeon based in and around Manchester in the UK, and I specialise rare for an orthopedic surgeon in shoulders and knees, arthroscopy and sports injuries that way. So the aim of my talk really is to discuss how imaging can impact on my clinical practice, and maybe to provoke some ideas about how imaging can impact on all our clinical practices from everyone listening. As part of that, I should explain what my clinical practice is. It's sports trauma and arthroscopy mainly, so less bony, but more soft tissue wise in terms of orthopedics. And as I say, I focus on shoulder and knee, but I don't do any arthroplasty at all. So you might instantly think that my emphasis will be more on ultrasound and MRI scan rather than X-rays. But I also would say that X-rays are still very important in terms of understanding the bony anatomy that we're dealing with. So what I want to do to start with, I see there's 15, 16 people listening in. Thank you for attending. I just wanted to take 10, 15 seconds to answer this question in our own minds. Why do we do imaging? Why do we as practitioners ask for an image or a form of imaging? What is it we want to get out of that imaging? for that patient. And then what I'm going to do is explore maybe a couple of potential answers, because it's limited in terms of interaction in our virtual world these days. So think about that. Has anybody said to gain a diagnosis? Now, you might not be able to tell me, but in your own mind to say you thought it was to gain a diagnosis. And you wouldn't necessarily be wrong. But rather than to gain a diagnosis, I want to divert back to something that's very rudimental in some ways. There's 1,000,001 different presenting complaints that a patient can have. And what we try and do is take those, narrow them down with history taking, narrow them down even more in terms of examination, and almost use the imaging technology to try and confirm what that clinical diagnosis or clinical suspicion might be. Through this progress, then, I'd suggest that rather than to offer the diagnosis or to make the diagnosis, it simply confirms our clinical diagnosis. And it's a subtle difference, but I think an important one, because the imaging alone, without the context of that clinical picture, is lacking, really. It's not worthless, but it's certainly lacking what it could be. But it's not the only reason we do imaging, in my mind. Why else do we do imaging? Well, what about to plan treatment? And so, as I say, I do shoulders and knees. If I'm planning a rotator cuff repair for a patient, I'll want to look at the imaging myself. As much as I enjoy the thorough reports of my radiology colleagues, I like to look at the imaging myself, because I've got the privileged position of being the only person who can have the clinical examination of the patient, look at the imaging, and then look inside the shoulder and actually correlate all three things together and create a database in my mind, which I can take forward to help other patients going forward in the future. If we look at these MRI scans, I think my cursor might be showing, we're looking at this. So I'm looking at this to say this is a tear of a supraspinatus, a tear of a rotator cuff. This looks an intact rotator cuff. So in terms of the operation that I might offer these patients, it's completely different kits that I have to organize, completely different time I have to book for theatre, completely different rehab for the patient, and slightly different risk profile for them as well in terms of the informed consent. So it helps me plan an operation. I mentioned x-rays, and these are quite two striking differences with x-rays that I know Shub's already touched on, and I'll come back to this in a bit, but an x-ray still is very important in my operative planning for pretty much all operations. So these are some of the features I like to look at in terms of planning a rotator cuff repair. I like to know clinically if it's an acute or chronic tear for the patient, and then on the scan, know if it's a partial or a full thickness tear. And if it's a partial tear, how partial? Not just that it's a partial tear, because partial could mean 1% of a tear or 99% of a tear. And how I'll treat those is very differently. I want to know if it's the supraspinatus, infraspinatus, or subscapularis, or a combination of all of them. I want to know the size of the tear, the length or the distance of the retraction of that tear. So what distance is it? Is it 1 centimetre, 2 centimetre, 3 centimetre, etc.? Is it beyond the glenoid? Because that's a very important feature as well. And then I want to know what the length of the residual tendon is, because that will dictate on really how much suture material I can get into that tendon and what type of repair I might be able to perform for that patient. But they're not the only things. I also want to know what the background osteoarthritis level is, whether there's any degree of rotator cuff tear arthropathy, and whether there's any fatty atrophy of the muscle as well, because that will also dictate and help me plan my treatment for that patient. But it's not exclusive to a rotator cuff repair. When we look at a shoulder stabilization, we can look at MR arthrograms using these axial sequences, and as I cycle through them, what we can see is that at the front of the glenoid, the anterior aspect of the glenoid, there's a gap. There's a gap here, fluids extravasating in there, and also towards the posterior aspect of the humeral head, there's a defect here, a so-called Hill-Sachs defect. And so what that does is that tells me that for this patient, potentially, I don't just need to address the anterior labrum, I might also need to address this Hill-Sachs defect, depending upon some measurements. So when I'm planning a shoulder stabilization, again, clinically, I want to know if it's acute or chronic instability. in terms of the labral tear, I want to know the size and where on the clock face it is. So the site, I want to know if there's any glenoid bone loss, and if so, what the amount is. Shub has touched on a Haggle lesion, a humeral avulsion of the glenohumeral ligament, and we can see those on the MRI scan as well. And I want to know if one of them is existing. And then on the humeral head, the Hill-Sachs lesion, I want to know what the width and the depth is, because that'll help me plan the right treatment and the right operation for the patient. On the right of the screen here, I've popped on some pictures showing the glenoid track, as it's called. And this is an equation which measures the circumference of the circular aspect, if you like, of the pair, inverted pair glenoid. And if we've got a bone loss of greater than 17%, the suggestion is that a bony procedure might be required, particularly when combined in the presence of an equation to look at the Hill-Sachs defect. That's quite a complicated philosophy, but certainly one that's very popular on continental Europe as well. I do knees as well as shoulders, and it's not just a shoulder orientated talk. We're going to talk a little bit about knees, and on this image I want to focus on the lateral aspect here. So as I cycle through these images, we can see that there's an issue with the lateral side and the lateral meniscus. We compare the meniscus here to the meniscus there, but there's also an extruded fragment here that's flipped into the notch. And that helps me plan this operation. It's telling me that this is a large bucket handle type tear, confirmed in the sagittal views as we scroll through. That was the medial side. We're now moving on to the lateral side, and we can also see the lateral meniscus here is empty. It's actually sitting here at the front with this vertical stripe separating the anterior horn and the flipped fragment from the posterior horn here. What I'm looking at here is to see whether or not this is something that I can repair, or I'll be required to have to remove the meniscus. And as we know, saving the meniscus is really good and really important in terms of long-term survivorship of that native knee and delaying osteoarthritis for as long as possible. So ideally, I want to repair. I want to know if I can repair it or whether I have to, excuse me, take it out. By that, I want to know the site and the type of the tear. I want to know how displaced it is, but also, as I highlighted there, if it's adherent or if it's not adherent. Because if it's not adherent to the anterior horn of the meniscus, I've got a better chance, obviously, of replacing it, pushing it back in, rather than having to dissect it away. Because in the process of dissecting it away, I might damage the residual meniscus. And indeed, it suggests a chronicity, which would mean a lack of likelihood of a successful repair. I want to know if there's any chondral injury. And if there is, the site of the chondral injury will guide where I place my portals, and it will also guide the position of the knee in terms of flexion that I need to get the knee into in order to access that chondral site to work on it intraoperatively. Also, if there's any loose bodies in the knee, I want to know where they are. It helps me when I go in and try and find them. You can also develop a suprapatellar recess, which is effectively a healing over of the suprapatellar pouch. And sometimes you can have a loose body trapped within that recess. And if you'd look inside the knee, you wouldn't see it. You'd have to release the fibrous wall to that recess before you can access the loose body. So it's always worth looking out for that. And also, if there's any posterior loose bodies, it guides me in whether or not I'll need to form a posteromedial portal to help remove them. So there's lots of things really I can use on a knee MRI scan to help me plan a knee arthroscopy. So we've done diagnosis, we've done treatment. We can also use imaging to help predict outcomes. Remember this image. Both these patients, the right shoulder patient and the left shoulder patient, have got a rotator cuff tear. But I know, based on studies and based on my experience, this patient here on the left with this proximally migrated humerus head rubbing against the undersurface of the acromion, so-called acetabularization of the acromion process with cuff tear arthropathy changes, won't do as well from a rotator cuff repair on the whole as this patient with a normal looking x-ray. The other things we mentioned, do you remember this slide? We mentioned background osteoarthritis. They don't do as well following a rotator cuff repair. Cuff tear arthropathy, they don't do as well. And fatty atrophy that you can see on an MRI scan, they don't do as well either. You might be able to repair the tendon, but then it's really difficult to really fire up that muscle if it's turned to fat. So to summarize, I think we've demonstrated some clinical applications of imaging. Certainly in my practice, they can help confirm a clinical diagnosis. They can help plan an appropriate treatment, or in my case, an appropriate operation, and also help guide our patient to predict the likelihood of a successful outcome following such surgery. Ultimately, it helps us work out how best to treat our patients and how best to get them a good outcome. So all that's left for me is to say thank you very much for listening. Thanks for giving up your time tonight. Thanks to PhysiQuip for the kind invitation, and thanks to Shub for sharing the stage. It's a great honour to share it with you. If anyone wants to follow me on various social media, my life's not that exciting, but you can follow me, or just drop me an email if you've got any questions directly for me. And then finally, apologies to PhysiQuip for this, because I've got a shameless plug. If anyone is interested in sports trauma and arthroscopy, please join our society in the United Kingdom. It's the British Orthopaedic Sports Trauma and Arthroscopy Association. You can follow us on the Twitter. You can link in via this website, and do feel free to check it out and join. We run an annual conference full of great talks in sports medicine that way. So I'm going to hand back to Jack, and Jack's got a few questions. Thanks a million. Thanks
very much, Neil, and thank you as well, Shub. I hope, I'm sure that everyone took a lot of value out of that. It's a pleasure and an honour to have you both join the stage with you as well. So yeah, thank you. I know I found it very informative. So yeah, thanks very much. So we're going to move on to the pre-submitted questions. Hopefully we'll get through all of them. And if there are any live Q&A questions that come through, we'll bring those up as well. So I'm going to just open those up now. Who wants to go first? Shub or Neil?
Shub will go first. He's muted. You can't say
cool. So question for you then, Shub. I've got a question here for covering around sort of pathway referral, and the individual's asked here, do you think that pathway referral for imaging routes in imaging from primary are correct?
Thanks for the question. I'm just trying to work my way through that. So, do I think it's appropriate, the kind of current imaging kind of process from primary care? So, I mean, I can only talk from my experience based in the northwest of England. So this might vary certainly region to region, but I know certainly in my local area in Lancashire and Greater Manchester, you know, a lot of primary care referrals for musculoskeletal pathology, first point contact often goes through to our local MSK physiotherapists and CATS teams, where they tend to do the kind of whole assessments and usually the diagnostic workup. There are a few GPs that tend to do it, but then most of it goes through the MSK CATS pathway. And again, depending on the institutions that you work in, pretty much around the country, will dictate, you know, what kind of service level agreements you have with the kind of local providers in and around that area. And it can be quite variable, in all honesty. So I know that some of those referrals for imaging come through to Wrightington and Wigan, to our local NHS trust for imaging, whilst other imaging modalities don't. So, for example, MRI scans might come through to us, but ultrasounds may be provided by another third-party sector out in the community. And it can be quite, you know, right or wrong. Certainly from my point of view, if I'm reporting cases, you know, often you see on the clinical request card information about, you know, previous ultrasound has shown this or that. And when I look on my system, I don't have any information around the ultrasound. So, you know, it doesn't really add much more value to me, and I really don't know where that's come from. So it can be difficult. It's not easy. And I think, you know, we've recently amalgamated our community CATS teams into our trust. So a lot of the imaging now comes through us in-house. Which is a lot better. And I think it's a lot better for the patients, because we get to appreciate everything more holistically. We see from start to finish what's happened and what's been imaged. And not just that, it's about that communication and network that you kind of open up. Those channels of communication are really important. Certainly in musculoskeletal imaging, you know, I would like to think I take pride in my work in terms of, you know, having really good relationships with my clinical referrers, and whether they're orthopedic surgeons or physiotherapists and sports medicine clinicians, it's really important to me that I'm accessible to them and that we can all pick up the phone or send a text and discuss cases, whether they're easy or complex. And I don't think that's always the case everywhere. And that's where, you can run into problems. I don't know, Neil, do you have anything to say on that?
Yeah, I'd fully agree, actually, Shub. I think you're right. The crucial thing with it is communication and accessibility. Like, it's something I've really found over my time working, particularly in elite sport. The more accessible you are, the better that communication, the less ambiguity, the less confusion, and everyone really is all reading from the same page.
Yeah, I think agree with you both there. I think, working in and around Manchester and meeting individuals like yourself, I think one thing I've noticed around the Northwest is, yes, people of your caliber are all very well networked. And so, yeah, it seems like you guys are doing a good job from that standpoint. So I'll fire over a question to yourself now, Neil, if that's okay. So this question is around, so yeah, they've mentioned how much do the clinicians, I'm guessing that's directed at both of you, but how much do the clinicians think, i.e. yourself, think that muscle tightness contributes to joint pain?
I think that's a really good question. Thanks to whoever put that through. I think it does contribute. I think, when you look at the human skeleton and the way the musculoskeletal system works collectively, you've got to look at the kinetic chain. If the kinetic chain, especially muscles and the crosser joint, are particularly tight, you will increase joint reaction forces across that joint. And what's been interesting to me in practice and learning from, dealing with patients rather than just textbooks, is that different people will react to the same thing in so many different ways. And what I found, again, in elite sport, the elite sports people are so in tune with their bodies that they can get joint pain from tight muscles more than someone like me, who I don't think will ever be confused with an elite sportsman, would maybe feel in mine if I've got a bit of muscle tightness. So yeah, I do. I'd certainly agree with that as a principle.
Brilliant. Thank you. Okay, I'll question for yourself, Shub. We've got an individual here who'd like you to cover, I guess, some detail or some information around MRI T1 vibe for PARS imaging.
Oh, right. Okay, great.
You don't want me to take that one, Shub? No?
Happily, go ahead. It was a buzzer round. If you press the buzzer first, you're on. Yeah, I mean, good question. And, we had about 10, 15 minutes to give the presentation, really. And there's so much we could talk about. I mean, people that know me know that I can talk for hours, mostly rubbish, maybe. But, there was a lot to cut, there's so much we could cover. And each of these questions can have its own little presentation package. T1 vibe is basically a sequence, it's an MR sequence that has been around for many years, probably over 15, 20 years, I think. And it's not an unusual sequence. It's used quite commonly, if I'm not mistaken, in other kind of subspecialties of radiology. So in breast imaging and in cross-sectional imaging, I think in chest and abdomens. And vibes, for those that don't know, vibe stands for volumetric interpolated breath hold examination. And it's just another type of sequence, no different to a T1 or a T2 or a STIR that a lot of you may well be used to. And the reason why this is, I suppose, making, I won't say a comeback, but kind of making an entry over the last kind of few years into MSK imaging is that the sequence is very much kind of orientated to kind of mimic CT scanning. So we know what the kind of superiorities of CT when it comes to discriminating bone from soft tissue and being able to kind of identify cortical bone from medullary bone. So with T1 vibes, these can try to mimic almost the same thing. They may never be as good as CT, but there are some advantages which I'll talk about. So with a lot of the kind of elite athletes and certainly a younger cohort of patients that we may deal with, and in the context of PARS defects, so we're now talking spine, there's certain sports people that may well be prone, and you see a lot of PARS type injuries, bony stress injuries in kind of cricketers and footballers and tennis players, etc. And if we do a standard MRI scan that covers your T1, T2, and stir sequences, yes, you may well be able to see bone marrow edema as a result of a bony stress injury. And sometimes, for sure, you can see the underlying fracture lines through the pars interarticularis, particularly if it's a complete fracture, and they're much more easier to pick up on MRI. But sometimes you don't see those fracture lines on the T1 imaging, which I always call the truth sequence, the anatomical sequence. So it's the kind of first thing I look at to delineate anatomy, and then use a T2 or a stir sequence to be able to help me tease out the pathology. But it's those incomplete fractures that can be a struggle with MRI scanning, and you would often then potentially go on to have a CT scan. And we know that CT scans carry a high burden of ionizing radiation dose to patients, and particularly when you're considering a younger cohort of patients, is that a burden you want to take? And particularly if you're performing serial imaging, which we tend to do a lot in the elite sports world, particularly to check on follow-up progress of healing of fractures and injuries, that might not be the right imaging test to go down. So a T1 Vibe really came in as a kind of substitute. And though it has a very low contrast resolution for soft tissue and condyle pathology, which is why it's not routinely used, it has a very good discriminatory factor between cortical bone and kind of fatty bone, medullary bone. So it's a sequence that can have very thin slices that can almost substitute for a CT scan. So in pars defects, in the younger cohort of patients, we now start to run in certain patients an additional T1 Vibe sequence that can give us the answer, particularly to assess for those incomplete fractures. And it's not just pars and the spine, it can sometimes be labeled as a pseudo CT study because it's used, and I have used it in previous years for other body parts. So for example, in the shoulder, Neil and I both talked about glenohumeral joint instability and Hill-Sachs lesions and bony Bankart lesions. Bony Bankart lesions can be difficult to find on MRI if you've not used the correct sequences, or if it's a subtle minimally displaced bony Bankart. So I've tried T1 Vibes in shoulder arthrography as well, and that's often helped to bail out and be able to delineate those glenoid fractures. So there's a lot of other areas that we can use T1 Vibes in, and not worry about having to go down the route of an additional or serial CT scans that particularly involve ionizing radiation. Sorry, that's pretty a long-winded answer to.
No, thanks. Really, really comprehensive answer there, Shub. Thank you. So yeah, I'll fire one over to Neil now. And I imagine this is probably different depending on who you're looking at, but individuals ask for sort of potential recommendations of dosage for steroids within small and large joints.
Yeah, it's a fair question. I think the steroid actually, it's pretty standard. The one I give, I give it 40 milligrams of Kenalog in the knee. I give it in the shoulder as well. If for whatever reason the patient has an allergy to Kenalog, then I'll use depomedrone, and I use 80 milligrams for that, because that's the kind of conversion dose, I suppose. I don't actually know what my colleagues use in the small joints in the fingers and toes. Shub might know better than me, because he probably injects multiple joints under image guidance. So is there any difference, Shub, in fingers and thumbs and stuff?
Yeah, so I think I'm with you in that most of my intra-articular joint injections are Kenalog, so triamcinolone acetonide, which I use 40 milligrams of as a standard dose. And if we're injecting into smaller joints, for example, the thumb CMC joint, which you commonly do for arthritis, or in the finger joints for arthritis, then you're probably using half that dose, maybe 20 milligrams of Kenalog, 10 to 20 milligrams, depending on what you inject. Biceps tendonitis or around the biceps tendon sheath, we tend to inject a lower dose steroid as well, purely to mitigate or minimize the risk of any unforeseen biceps tendon rupture. And similarly in the foot and ankle as well, we don't routinely inject steroids, but if we get asked to, in customized patients and athletes, then we may well consider lower dose cortisone into the tendon sheaths around the ankle tendons. So there's no kind of, I suppose, right or wrong answer, but you kind of titrate up. And of course, if those of you out there that are injecting cortisone, I think it's very important as well just to have a good background medical history of the patient. Have they got any other potential conditions? So Kenalog, for example, I wouldn't use if somebody has got HIV or on antiretroviral therapy, because of the effects of Kenalog on viral load. And similarly, people that are epileptic on certain anti-epileptic medication, Kenalog in particular can reduce the seizure threshold. So then you would consider the alternative steroids like either hydrocortisone, but more commonly I use depomedrone as well, methylprednisolone, whether it's 40 or 80 milligrams, etc. So yeah.
Thanks. Thank you both. So yeah, Shub, just a question around sort of the MSK ultrasound of the shoulder. An individual here is looking if you can sort of cover off some of the pitfalls, perhaps of MSK ultrasound of the shoulder joint.
Yeah, so I mean, I'm just trying to read your question there in terms of MSK ultrasound and glenohumeral joint or shoulder joint. So ultrasound, though its usefulness is very good at assessing the soft tissues and the rotator cuff tendons, etc., ultrasound is not the right imaging modality test if you're trying to evaluate what's going on within the glenohumeral joint proper. So if you're looking to see if there's any underlying chondropathy, or in the context of arthritis, ultrasound is not the go-to imaging test. If you're wondering if the glenoid labrum is torn or damaged, then ultrasound is probably not the correct imaging test. Now, you can see things like the posterior labrum when you're scanning the posterior glenohumeral joint, because you get a nice view of the posterior labrum, but you only get part of a view. You don't see the entire posterior labrum. So irrespective of that posterior labrum looking normal or not, you can't really comment on the rest of it. So there are some drawbacks with ultrasound when you're looking for intra-articular structures. And then you've got artifact as well around ultrasound in terms of anisotropy, where you can make something look whatever you want by moving your probe around, and in terms of scanning and scanning technique. And so it takes, I guess, a lot of experience to be able to scan and identify what normal structures would look like before you start to go down the route of labeling something abnormal. But specifically to your question, if it's about the glenohumeral joint, ultrasound isn't the appropriate imaging modality to assess the glenohumeral joint in particular.
Brilliant, thank you. Thanks very much. Question for cover a few off for Neil now. I've got one here. How effective would you say standard X-rays are in identifying the scaphoid or fractures in the scaphoid?
I think they're pretty good. I don't know what the actual values would be, but they've stood the test of time for many years. I think the thing we know about scaphoid fractures and X-rays is they don't always appear on the first X-ray. So the common practice is, if the clinical indication is that your suspicion is quite high of a scaphoid fracture, you should repeat the X-ray in 10 to 14 days. And that's something we've done ever since I was a junior doctor in fracture clinic from what I can remember. What we know now, though, is if the fracture isn't visible at 10 to 14 days, but you still are fairly impressed by the clinical findings, now rather than putting someone in a plaster cast for 6 to 8 weeks and leaving them in the plaster, you should get an urgent MRI scan, because that's what will really define the fracture or not. And from that, you can then determine, right, do I have to treat this patient in a scaphoid cast for this undisplaced, by definition, because you can't see it on an X-ray, scaphoid fracture. So they'll be treated in a cast for somewhere between 6 and 8 weeks, which ideally, if you can avoid, you wouldn't do. Or can I safely say they haven't got a fracture? And if you can safely say they haven't got a fracture, there's no need for the cast. So yeah, I suppose X-rays still should be the first investigation modality for scaphoid, but we do have other options now compared to 10, 15 years ago.
Yeah, thank you. So Shub, a question around imaging for sportsman's groin. So individuals ask, what is the best imaging that you could potentially suggest for sportsman's groin?
Thanks, Jack. Thanks for the question, whoever posed it. It's got a complex answer. It depends what you mean by sportsman's groin. And, everyone, might have a different perception of it. But, ultimately, I take it as, sportsman groin pathology to include anything that might potentially be intra-articular from the hip joint that might radiate out, causing referred pain. So I'm looking for things like labral injuries. I'm looking for any psoas-related problems. Going more medially now towards the symphysis pubis and assessing the plaque, the pyramidalis, the adductors, the symphysis pubis, the adductor fibrocartilage plate, etc., and the adductor muscle groups. And again, depending on what you're looking for, will dictate what imaging modality you use. And then you can throw into that mix as well hernias. So is it an inguinal hernia? Is there inguinal wall disruption? So there's quite a catalogue of pathologies that get encompassed within that sportsman's groin. And, to be honest with you, my go-to usually is an MRI scan, but I always like doing an ultrasound scan as well. The reason being, with ultrasound, it's a dynamic test. I can access all of those structures. I can talk to the player or to a patient to see where their symptoms are. I can try various things like increasing the intra-abdominal pressure with Valsalva maneuvers to see if I can tease out any hernias. And try different positions and movements where the patient can replicate their symptoms. And I find that ultrasound is quite a useful adjunct as a dynamic study to then moving on and doing an MRI scan as well, which gives us more information that an ultrasound may not. For example, looking at the bone marrow and looking for any bone marrow edema, and looking at all the kind of structures together in terms of, is there any is there a bigger picture going on here, and that I can then put into my report. So I tend to use both ultrasound and MRI actually for assessment of sportsman groin, unless one of them gives me the clearest indication altogether. And sometimes you can get dual pathology, so the question then falls back when you do the reports back to the clinician that, look, we found this on the ultrasound and we found this on the MR. You might find 2 or 3 pathologies, and then we throw it back to the clinicians to then re-examine and reassess to work out which is actually the most likely offending pathology. So, yeah.
Thanks very much. Just getting through some of these now, to find some that we haven't covered off. So, yeah, a bit of a mouthful, this one, but question for yourself, Neil. How valuable do you feel the Frederickson's classification of tibial bone stress injuries is to guiding prognosis? So maybe you can both have a crack at answering.
I was hoping you were going to say the question about acromioclavicular joint and glenohumeral. I know you're still avoiding that, Jack, aren't you? We'll get to that.
We'll get to that.
This is a really good question. So the idea of a classification system is, number one, to be reproducible. Number two, to be easy to understand in that way, to have a high intra and inter observer reliability, so that both me and Shub can look at something, call it the same classification today, and then in a 10-week period, look at the same thing again and give it the same results. And the idea of that is that then there's some consistency to it, so that if we can then use it as a framework on which to use our management and treatment for something, we can reliably predict things. And when we're first starting off in medicine, certainly, and in practice, it's nice to have these kind of flag posts that we can really nail things to. The Frederickson classification, to be honest, isn't one that I'm greatly familiar with, because normally by the time a patient with the medial tibial stress syndrome, which it describes, comes to me, they're a grade 4 anyway, so they've got this kind of fracture line visible. So in terms of my practice, I don't really find it that useful, but I can see that in terms of sports medicine and the sports medicine world and sports medicine docs and rehab docs that way, it would probably be more beneficial to them, because it would help guide their management up until the point where I'd get involved as a surgeon, I suppose.
Brilliant. No, appreciate you answering the question. So yeah, we'll go for we'll go for one more here then. So again, this one could be for yourself, Shub or Neil, depending on who's more comfortable on this one. But Someone's interested to learn about when to refer for MRI and handy tips with using ultrasound for the glenohumeral joint and the acromioclavicular joint. Do apologise. Clavicular joint.
Well done, Jack. Personally, my thoughts on when to refer for an MRI scan. I'm quite MRI happy, I suppose. You know, I like an MRI scan. I still don't think we should forget about an X-ray though. An X-ray is really important for a lot of reasons, and I'd always go for an X-ray first and then supplement that with an MRI scan. As for tips and tricks with ultrasound, I think Shub will be better positioned to answer that one than me.
Yeah, I mean, look, I love reporting MRI scans, so as long as Neil's requesting them, I'll be happily reporting them. You know, ultimately, when you're requesting any imaging modality, though, I think it's really crucial that you know, as Neil's alluded to in his presentation, when you're seeing patients, the whole concept is that you know in medical school we were taught that 70% of your diagnosis comes from that initial history taking and examination, you know, sticking, you know, your hand on someone's tummy or moving their arm around, and you make that differential diagnosis just from that, you know, 70% of the time. And then that last 30%, you're using tests and investigations, whether they're blood tests or whether they're imaging tools, to try and nail down your differential in your differential diagnosis. So that's where imaging can come along. And that's how I would like to see imaging being used. I'll be honest that I think we're now living in an age where we've kind of moved a lot forwards from that, probably not in the right direction necessarily, whereby imaging is being very much used as a triage service in a way to kind of work out, right, what's the problem, you know, particularly because, you know, we become a victim of our own success. If you need a CT or an MRI scan, you can get it relatively quickly. And people just get put through the scanner. And, you know, one of my bugbears is that you get a referral with a differential diagnosis that's like, you know, an A4 piece of paper. And, you know, to me, that tells me, well, okay, maybe the clinical referrer here is not fully engaged. You know, we're not really sure what is exactly the kind of offending problem here. We haven't nailed down a differential to a narrow list. And that makes it difficult, because then when I come to report such a case with MR, you know, it's much more difficult to work out, okay, is this a relevant finding that I found here, or is that a relevant finding? And then, you know, my differential on my conclusion or impression at the end of my report becomes long. I don't know if that's really helpful then, but, you know, to the clinician and more so to the patient. So you've got to select the imaging wisely to help discriminate your differential diagnosis. And also to make sure that it actually actively changes your management, you know, beforehand. So that's what I'd say for MR. In terms of ultrasound, accessibility and training for the glenohumeral and acromioclavicular joints, I mean, if you're wanting to learn ultrasound, you know, it's a long drawn out process. You know, as with anything, you know, experience tells, and, you know, the ultrasound is a very practical imaging modality. So it's not something you can just look at images with. You know, when I teach on courses, you know, I often pick up the ones that are pretty much starters with ultrasound by the way they hold the probe. And there's a lot of telltale signs that you can tell of who's quite advanced in their ultrasound practice and who isn't. But with ultrasound, you really need to just get a machine. I know PhysiQuip do lots of nice machines, for a little plug there. But using machines and just scanning and practicing on yourself, practicing on your friends and family. And then, you know, the more you see, what you need to do is build up a memory bank of what normal is. If you don't know what normal is, then it's very difficult to then be confident on what an abnormality will be. And this only comes with time. So you need to carry on, you know, training yourself, attending courses and conferences. You know, if you're struggling to find mentors, you know, contact your local hospitals, you know, sonographers, practitioners, radiologists. You know, plenty of people are there to be able to help and support potentially.
Yeah, definitely, completely agree with you there, Shub. And it's I think something we pride ourselves at PhysiQuip is, you know, putting individuals in touch with, you know, that network of people who can act as mentors. And I think, yeah, especially with ultrasound, it's incredibly important to practice and find that mentor. So finally, with finally pre-submitted question, and we will move on to the Q&A. Neil, I think this would be one for yourself. So could you tell us a little bit when imaging may be not necessary for a diagnosis?
It's a really good question. when's it not necessary? It's probably when it's not available, or if you feel supremely confident of your diagnosis. I think in the modern day and age, certainly in my practice in the UK, it's very available, as Shub's just touched on. So, for instance, I might be super confident that someone's torn their ACL or torn their meniscus. To gain a diagnosis, maybe I don't need it, but I kind of want it because it helps me plan my operation better for that patient. In the shoulder, you might think, well, okay, I could go into the shoulder and deal with what I find when I'm there. Is it really going to help with the diagnosis that way? Well, yeah, I think it does still. So I think traditionally, when you maybe only had a certain number of scans that you could allocate to your patients, if you had to kind of pick and choose, yeah, you might pick the barn door obvious clinical cases to maybe just say, we don't need a scan or we don't need imaging for this patient. But I think in the modern day, it's really a vital augment to our care for patients, really.
Yeah. Thanks very much. So yeah, a question from the live Q&A here, and it's a question for Dr. Shub. So if a dynamic MRI scan were available for the shoulder, would that then change the management of the patient?
That's a good question. I mean, I suppose, will it change the management? Will depend on the pathology and the clinician and who the clinician is and how they act upon it. I'll be honest, I don't have much experience with dynamic MRI imaging if it's a case of positioning patients into different areas. So of course, we know that MRI is a static, generally a conventional MRI scanner, that is a static imaging test where patients are often not load bearing and they're lying down most of the time. And patients may come out and say, well, I only get pain when I'm abducting my shoulder, doc, or, when I'm stood up, or I get back pain when I'm stood up. There's various connotations, yet when we scan, that we're scanning them in a kind of non-physiological position, and then the information we glean out of those scans are in a non-physiological position. Now, sometimes that will give us the information and highlight the pathology, but then there might be a very small cohort of patients where the scan doesn't necessarily turn up the right answer. So I suppose there may well be scope then for dynamic imaging with MR kinematics. And I know I've worked with some open scanners where we certainly, when it comes to the back, for example, or the spine, we can scan patients load bearing with them kind of stood up. And you can see how some of the exit foramini in the spine or the lateral recesses can close down upon weight bearing. Similarly, with some of the other joints, you can potentially maneuver and provocate certain movements and positions and scan patients in those areas to see whether that has any kind of implication. But I would say that the imaging then gets distorted as well, and it's as much a learning process for me as a reader of the scan and as a radiologist to be able to work out, what normal is, even in a kind of dynamic position, which will be very different to how we're used to reporting current conventional scans. So yeah, definitely, I think there may well be scope for that, but I have limited experience.
Brilliant. Thanks very much. So that concludes all the questions and the webinar this evening. I want to thank everybody who attended tonight. Really appreciate your time, and thank you again to Dr. Shub, Dr. Neil, for your time, not only your time, but also your expertise. I'm sure everyone took value from it, so thank you very much. And for all the attendees following this, you will receive a survey along with a link to the webinar recording if you want to watch anything through, or if you might have missed anything. We'd really appreciate your feedback and suggestions for future webinars in the survey. You can also register to the PhysiQuip Academy. That's going to give you access to all our past webinars and educational resources. And again, if you've got any other further questions or want to know anything about some of our further products, particularly maybe the diagnostic ultrasound that we do supply, feel free to reach out. Our email address is info@physiquip.com. Other than that, have a great evening, and thanks all again for attending.
Thanks, Jack. Cheers. Cheers, everyone. Good evening.
Cheers.
Cheers. Bye.